Dear audience, welcome to the Global Healthcare Travel Council medical webinars presented to you by cooperation with the Near East University. Today topic is dyspnea cases and treatment from the chest point of view. Our speaker today is the respected Professor Dr. Fen Ramussen. Professor, I would like to invite you to the stage. I would like you to introduce yourself to our audience.
Thank you. My name is Professor Finn Rasmussen. I worked at Near East for 10 years, but now I'm associated with Lifelong Health Center. And by the way, the talk is not that talk. That was held for approximately half a year ago. The talk today is diagnostic and current therapy options on allergies. So I think you got it a little bit wrong, but I guess it's still an interesting subject. So I hope that you will find that interesting too. And that's what was announced for the talk today. So just to make sure that there's no misunderstanding, I think the staff at Near East didn't get it right, but that can happen. I will continue from there. Is the slides up? Can you see those?
Not yet, Doctor, not yet, Professor.
Because
yes, now it's loading. Yes, we can see it now clearly.
Okay.
Thank you.
Okay, so diagnostic and current therapy options in allergy. And as I said, I'm Finn Rasmussen. I work in Nicosia, Lifelong Health Center, and if you want to contact me, there's info there. And I will always be helpful if people, either patient or other health professional, wants to get some help. Okay, so let's see. How can we change this one maybe? Yes. Okay. So just to get it straight, we are talking about IgE-mediated allergy response. And one of the perception that many get wrong, both doctors and patient, is that you actually need to be exposed to it to be allergic. So that means that the first exposure or thereafter, there is a sensitization. That means that you have a hyperreaction in your body and you kind of are prone to it, but you don't have any symptoms. So you can easily go around, be sensitized for something without having any clinical reactivity. When you have the clinical reactivity, that means that you subsequently get a re-exposure or consumption if you eat it, then present symptoms, and then you call it allergy. That means that not every test that you do that actually is positive is necessary an allergic reaction. It's definitely a sensitization. Just to keep that straight, because it means that it's just not straightforward to look at the, for example, interpretation of an allergy test. So that's why I would claim that you need allergic doctors to kind of do that. If you then look at the symptoms, it's actually quite easy because you mainly have symptoms from three organ systems. It's the GI, it's the skin, and it's the respiratory system. And why those? It's because they are actually turned towards the external world. And that's where we mainly need to be protected from the outside, where virus and bacteria and so comes, parasite. And why there, then sometimes it's not convenient response, it's a hyperreaction like an allergy. And if you have it a combination of all and very severe, you have this anaphylactic reaction. That is life-threatening and you might die. So basically, when you look at what is allergic symptoms, you can just look and learn from anaphylaxia. And if you look at, for example, the airways, you have coughing, shortness of breath, wheezing, chest pain, tightness, difficult swallowing. If the nose, it's stuffed nose, running nose, sneezing. If it's the brain, it's anxiety, confusion, headache. If it's the heart, it's dizziness, weak pulse, stomach, nausea, vomiting, diarrhea, stomach pain, and cramps. And of course, the skins, it's hives, eczema, itching, and so on. So actually, you have all these symptoms, and what you notice is, of course, they're not specific for just allergy. It's a reaction there, but if you have these, you have to think that you might have a disease that is within the allergic area, but not necessary. Remember that. And again, if you look at diseases, you have this type 1 EGM-mediated allergy. Could be anaphylaxis, would come within minutes or at the most an hour. And then you have the other ones that can mimic. We all know that, for example, you can have destruction in, if you take penicillin and you are reactive to that, you can have a hemolytic anemia, for example, but that will not be a type 1 IgE mediated reaction. It would be a non-IgE mediated. And often the tests we are doing are mainly IgE mediated. Other could be Steve-Johnson syndrome and other symptoms in the skin. It doesn't matter, but mainly what you notice is it is also connected to these symptoms. When I wanted to talk in this, I have half an hour, so I have to kind of select what diseases and what kind of complex I want to choose. And here I choose from the respiratory system, asthma. Why asthma, not why rhinitis? Because asthma is kind of more life-threatening. The other one is quality of life. It's important, and us allergists would know that. But asthma is kind of something that you actually can die from. So I thought that would be more important to kind of address, and also important the way that what I see is that many doctors are not fully updated with the current guidelines of how to start treatment. And I want to address that. If you look at the diagnostic testing, you can see here is an algorithm, and it says age over 16, but in reality it's actually age over 5. There is, because from there the people, the kids and also the adults can actually do pulmonary testing, and they can do other tests, and you can kind of do, for example, an allergy test on them without them getting too traumatized. What you should do is illustrated here. You should screen first with a blood test or a nitrooxygen test. And of course, if they have actually symptoms of dyspnea or wheeze, you should do a bronchodilatator test. If that doesn't give the answer, you proceed with peak flow variability. And very rarely, actually, if you really do an effort on the clinical history and the test, you basically have the diagnosis in 90-95% of the cases. If you don't have it, you should move on to a methaqualin or a mannitol test, in my opinion, or a exercise test. So how do you interpret it? Of course, it's not. You have to remember, in the literature, yes, we try to put some cut points for making the diagnosis easier and kind of increase the specificity and the sensitivity. So here is some suggestions of the cut points you should choose. You could, for example, when you look at the bronchodilatator test, it is, of course, important to know that if it's a change from 1.6 to 1.7, it might be in the percentage high, but in reality, the absolute values are very small and within the limitations of the measurements of the lung function test, for example. So what you have to address is you have to input it into the context of the patient's lung function, ability to perform the test actually. And also the same when you look at the eosinophil count, you have to look, did you take it in the same time that the patient had a bacterial infection? Then it might be falsely low compared to if it was in a normal state. So all these things you have to take into account. Also the nitrogen oxygen, you have to look, had just been smoking, that will also affect the result with lower values, and then maybe they cut the cut points. So there's many things that when you actually look at the patients you have and make the test, you have to know and understand the underneath reasons and the underneath things that can affect the test. Said that, when you look at the asthma, there's basically 5 to 6 things you should do before you do anything else. You should use inhaled corticosteroids. You should use long-acting beta agonist or supplement with long-acting muscarine agonist. You should consider immunotherapy like either sublingual or subcutaneous. And of course, I think the slit is definitely for kids. The subcutaneous is if they are a little bit older and easier, then it's easier for them just to have their symptoms once a month instead of maybe symptoms every day in the morning that they have to take the medicine and then wait 15 minutes before they can eat. So somebody would notice that I put gray on the short-acting beta agonist. And that's where I think the doctors now, they should actually not use it as the first choice. They should use a combination and preferable formoterol with inhaled steroid if you have diagnosed asthma, as also reliever medicine. It functions very well, and the patient will only need one inhaler. Of course, you can do the other things, but I think that's old-fashioned, and it's kind of something that we should go away from. If you then look, what do you want to achieve? And what you want to achieve is, and here I'm talking about patient over 5 years. You should definitely have a proper diagnosis before you give them medicine. You should also, if they have a proper diagnosis of asthma, teach them how they actually can manage themselves in the main thing. I know that we are, especially in Cyprus, having a little bit a commercial system, but for the sake of ourselves and also for the sake of especially the patients, we should teach them how to manage their disease for themselves mainly. And don't worry, we will have enough to do because we will need, or it's suggested that you should be controlled at least once a year with a lung function and a follow-up. How is it going? Are they actually managing their disease properly? And that could be once a year or every half a year, you decide. Of course, depending on the patient's abilities and symptom control. And also, if they actually go to the hospital and have asthma attack, you should definitely make a follow-up in the ambulatory or at your clinic to make sure that they actually understand what is happening. And I know that you cannot always control that, but at least you can suggest them to take an action and contact their doctor in charge. If you then have severe asthma, which is a total other aspect, my opinion is that it has to be, and also the guidelines in the world is that you have to consult a specialist. So, and why should you do that? Is because if it doesn't work, you have a lot of diseases you should look at. But of course, first think, are they actually taking their medicine? Do they still smoke like a chimney? Do they have other things that affect them, like cardiac morbidity? Do they actually take their cat out as they promised to, or are they sleeping with the cat? So those things first to actually improve the treatment, and you would be surprised how much time and how many patients you actually can save from further treatments by actually just looking very thoroughly into that. Still, if they don't present any of the things, you should think tracheomalacia, you should think bronchiolitis, which you can look at a HRCT scan. If you have primary ciliary dyskinesia, it will often be very small children. It will be diagnosed, but it can come later on, and then you can look at, for example, nitro oxygen in the nasal exhalation, and of course cardiac diseases, you transfer it to the cardiac doctor, or you can screen it yourself by ultrasound, and if you find something, then send it to the cardiologist. I think you should let the people who knows the best about it treat the people that has that disease as a specialty. If that doesn't work, you should definitely, sorry, I got disturbed. You should definitely think about other treatment possibility, like biological treatment, tailoring the main problem here. And there is some drugs available actually now. There's not that many in Cyprus, but if necessary, of course, we can take them from other countries and present for the patient. But again, I must stress that they are very expensive, so you should definitely have excluded all other possibilities. And in my experience is that you can actually nearly treat 99% of all asthmatic without it, if you really put an effort in it. But if you do, if you can't, you should think, for example, omalizumab, Xolair. That is basically for the allergic patient. It's very easy. It's available, for example, in our area of the world. It's around 12,000 Turkish lira per month in cost. So it is within the cheapest one of all these. The other ones are much, much more expensive, and they come into play if the Xolair doesn't work, in my opinion, or if it's not allergic, it's an eosinophil type of asthma, and it's still, remember, it's an add-on. And again, prefer the subcutaneous ones and not the IV drug. If anybody needs help, I can be available for helping in these, but I have to stress that they are expensive, and for most people in our area, it's not a real option due to the costs. But if you decide, there is some helping here, where you, of course, as I said, look at the phenotype. It's more personalized medicine. At least it's going towards that, where you look at the eosinophil count, you look at the sensitization of allergens, and then you select these different medicines according to that. I think induced sputum is not really useful, even though I worked at McMaster University in Canada for a year, but my impression was that many even there didn't use it. It's very difficult, and the variation is very high. So I think you should start to the blood tests that are validated, and move from there in these issues. Moving on, if you look at the gastrointestinal tract, you have like some very common syndromes of allergic reactions like eosinophilic esophagitis, oral allergy syndrome, which is actually mainly a cross-allergy problem, for example, where proteins in pollen resembles proteins in foods, and the classical one is grass and nuts, for example. And then there's food protein-induced enterocolitis syndromes and allergic proctitis. But due to the waste kind of symptoms and prevalence, I think general food allergy is the thing we should talk about. And here it's important to remember to distinguish between food reactions and other reaction. And it is difficult. Even like a food allergy and irritable bowel syndrome, as illustrated with the symptoms, nausea, stomach pain, diarrhea, and so on. So wrist and cramps resembles very much each other. So it can also and should be a collaboration between specialists of, for example, gastroenterology and allergy, if there is some doubt in what is causing the patient's complaints. If you then look at it for the testing, skin prick test or blood test again would be preferable, and if you have the suspicious, you should include or refer, and we do these big 8s because they actually diagnose 80%, 90% of all food allergies. And if you note those with a little star, that's the one that are most common in adults, and that's also the ones that are most prone to be continuing all lifelong. And we have milk, eggs, peanuts, tree nuts, soy, wheat, fish, and of course shellfish. If you then look at the prevalence, asthma is around 15%, so we are much lower, and these numbers here, I put it maybe a little bit higher than they actually are, but they are increasing. So the prevalence of food allergy are getting more and more relevant for even the normal doctors to at least think of, and then maybe refer to a specialist for. And when I say specialist, I mean there is in Turkey and in Cyprus, it's singular speciality, but in other countries it's often an under specialization of, for example, throat, lung, or dermatology. So there are different ways to arrange the allergy, and in my opinion, what is important is, of course, the knowledge of the doctor, so they can help the patient. I'm not so interested in who's doing what, and but of course you should have the knowledge and the education for it, according to your country. Yes, it's a little bit busy slide, but what I wanted to tell is that food allergy, you have to think it can be also cell-mediated. And one of the most common one that you all know is the celiac disease, which is found in gluten, of course, where it's not IgE mediated. That will be negative. It would be an IgG positivity that you prone that. So again, it is important that you know your disease and what are you testing for and how can you diagnose it. And again, it's important to know that they can actually be falsely negative. For example, if the patient has avoided a lot of bread before testing, So there's all these things that when you actually put testing and results and symptoms into a clinical context, you might sometimes be very confused about what is going on. I mentioned the oral allergy syndrome, and it says here the pollen deviated apotypes. Again, you have, especially in the Mediterranean area, again, symptoms that mimics allergy, which is a lactose intolerance. And of course, there's tests for it, but again, it's important to stress out that when you look at symptoms, you have to kind of put it into the clinical context and know your area of testing. And again, when you look at the kids' allergies, if you look at milk allergy, it will generally disappear. So if you change away from cow milk and other products, you might reintroduce it later on, in the sense that if you want to reintroduce it, you can maybe, because many of them will grow out of their allergy. If they don't, they often have some concurrent sensitivity to other food allergies. Then they have a higher probability of not doing that. Again, I repeat myself, the peanut, tree, fish, shellfish allergies are often lifelong. So there you have to address the life-changing more permanently. Food allergy is difficult, in my opinion. You really have to interview them a long time. It's a hassle because it's very important that you have a complete medical history. And often in food allergy, it can actually come in syndromes in a way that the allergy is only provoked, for example, if they exercise right after or right before or take a hot bath. So it can be an event where the order actually is also important before they actually demonstrated their allergy. So be aware of that. Again, skin prick test, I prefer that because you actually see the reaction. But if you use the proper blood test, like the ISAC or others, you get a similar result and they are comparable. But there is out there some allergy test where the specificity and the sensitivity is not good enough. When you go to the treatment and diagnosis, it can also be an elimination diet where you remove the suspicious food from the diet for a certain period of time. And it can be up to 3 months you have to do that. So it's a really, really heavy decision, especially in kids, to do this. And then after that, you can, of course, think about reintroduction, or you can actually do a food allergy challenge. And again, periodic re-evaluation is important. For more specific, not specific, but more rare tests, you can look at the BAT, the basophil activation test, and the max cell activation test. But if you do the other tests very thoroughly, it is often not necessary to go to these more expensive tests. So what is the treatment? The main treatment is avoidance of the allergy-containing food. But again, as I said, it may take some time before the intestinal histology is actually normal, and we say like a thumb around 3 months for that to happen, for sure. And then you should reintroduce the foods to see is it actually necessary to avoid it, because it affects the person extreme degree, because there's, for example, if you look at milk products or shell-free products, traces in nearly all supermarket foods around. There is tolerance. It exists. You can actually build it up. you have to start with very low doses and then slowly increase the dose. It cannot be done with all allergens. For example, gluten, it's not possible because it's not an IgE mediated. But for example, I had a patient once where it was, what is it called? Portakalsuyu, what is that called in English now? I only can speak Turkish. That's very funny. But anyway, most people will know what it is. And if you drink once a day, it is not a problem, but you may have a relapse of symptoms if you just skip one day. If you put the avoidance of the allergy foods, I would just say that you have to be aware that especially in kids, they might have problems with deficiency of vitamin and minerals, and preferable talk to your, that's what I do. If I have such patients, I always collaborate with a pediatrician. They should be involved in all these issues, and a dietitian to make sure that the child will develop properly in spite of their problems. And also, if you look at the elementary formula, that would be, in my opinion, a strong collaboration with the pediatrician to make sure that if they are needed to avoid very essential foods, that they actually get other foods that they or supplements so they can develop properly. Okay, the reason I'm taking this subject up, drug allergy, is that there's a lot of confusion about it, and there's a lot of questions about it, and often it's not a quick fix. Often you cannot just say before an operation the day after find out if they have penicillin allergy. That's not really an option, and I'll come back to that. That's why I will go through it, because I meet quite some requests on that. And why penicillin? That's the most common allergen, drug allergy. And the reason we love penicillin is basically can be given as a candy. Of course, I'm exaggerating, but it has, compared to other antibiotics, a very, very nice profile of side effects. So, and it's quite efficient towards the bacteria that are really, really harmful and can cause death. But of course, there's others. There is sulfametazole drugs, sulfamides. There is NSAIDs. There's acetaminophen. There's Morphica. There is like chemotherapy drugs. There's anti-seizure medication, local anesthetics, and contrast materials. And in principle, most of them you can actually do testing on them if you have an allergy, or there is alternative where you don't need to actually test it. If you have a very healthy person with penicillin allergy and you are not expecting them to ever need an antibiotic very often, you might just say, okay, you can't take that, and we will give you alternatives unless you kind of develop something. But then again, if you, for example, from a long point of view, have people with severe bronchiectasis or immune deficiency disease, you should test for that to make sure that actually when they get sick, you can treat them properly with penicillin. What you have to ask is a detailed reaction. Why? You look at the right, because it actually depends on and give you a clue about, is it IgE mediated or is it non-IgE mediated? So if they had a hemolytic anemia and Steve Johnson syndrome, you may not test anyway, and if it's very clear, you can say, well, you have an allergy and you should not be tested. But that's not the most of the patient. Most of the patient will actually have some of the the reaction on the other side, and you can easily test it. And also, of course, if they had it 10 years ago, you are also more prone to see if it's not on the non-mediated, non-IgE mediated. You can also test. And no, back just to say here, the desensitization is possible, and you can do that in a very ill patient, for example, in intensive care with a history. There is protocols to actually test for that if the penicillin is a necessary drug to save the patients. But otherwise, yeah, the reaction is in many different places on the penicillin molecule. That also means that the cross-reactivity changes and which medicine is affected other than penicillin. Here is just said that if it's penicillin, it is relatively rare to cephalosporins. There is some that says 15%, but I think my clinical experience, like I put on this slide from article, is more correct. It's relatively rare. So you don't need to be concerned on that. But if you want to do an allergy testing, you actually have to do quite some steps to make sure that they don't have it. You have to take a pre-testing of the penicillin, and you take all 4 that you can test for. Then you do intercutaneous tests, and here I put up which doses you can use, because if you use more higher doses, you have an irritation and you can't interpretate it, so it's not that easy. And then you do your provocation in your clinic, and which can take the whole day, and then after you do a 7-day challenge at home, and then again a month later you do new blood test to see if there's a new sensitization. So as you see, it's not just one step to actually make a proper penicillin drug testing. And I think many are not aware of it, and I just wanted to put a little bit of awareness on that when you kind of want to find out if they have an allergy and you want to test for it. The right way is here. Okay, the last topic, and then is urticaria. And the reason it's among the skin allergies that have been through all 3 organ system. Of course, there's eczema, there's swelling, which basically is also an urticaria, but there's no itching, and call it angioedema. And there's contact dermatitis, which you all know that it will either be irritant or allergic. And again, here I suggest that if you are not a skin doctor, you make a collaboration with the skin doctor, or you make sure that there is a scene together, so nothing is overseen. Again, I think there's a little bit confusion, and I see, I think if they have an acute urticaria, you don't need to do any testing. And that's also in the guidelines, because there's a 60 to 70% chance that it will disappear by itself, because it's often caused by virus or an infection. Yeah, you should look at the tonsils if they have an infection, or you should ask about urinary tract infection, but otherwise you don't need to do the major testing. However, we should do that when it's a chronic urticaria, because one of the problems with chronic urticaria is that sometimes there on long term can come a dissociation, a disconnection between what causes it and actually the urticaria by itself. What is that? That means that, yeah, it could be an allergen that provoked, it could be grass or something, but then later on it actually comes without the the grass or the one that normally causes urticaria. And then it just gets worse and worse and worse. And the patient, beside their symptoms, which is very, very annoying, but if it's within areas of the skin that is visible for others, most people actually get scared of the patient because they look quite different than normal. I have some examples, and imagine that you have that on your face, then people instinctively avoid you. And that's very, very disabling for the patient. It affects their life a lot. But here it comes. Here have your possibilities. You should do this is basically all the groups where the urticaria can come. There is a way to make it smooth. You will start with infections, medications, and physical stimuli to kind of exclude those. Then I would act on further on allergy, like a skin prick test, including food allergies. If they are negative, then I will go further to systemic disorders. If they have signs of systemic disorders already, you should of course go that way instantly and think about that. And when should you think about that it could be other than just the normal things is if their wheels are staying longer than 24 hours, you should definitely think systemic disease. And one of the problems is that you can also, of course, in that have the suspicious of cancer, but mostly it's autoimmune diseases in my experience. So again, if you can look at it a little bit, if it's located to the skin, it's often one of the issues up here. And I think especially, for example, South European, I see quite a lot of parasitic problems that provokes it. But the main cause is, of course, allergy. So again, an allergy test after screening the blood for others would be preferable. Here, just I thought it was a little bit nice study actually from Turkey. Just a slide where they look at what is the presentation in children with chronic urticaria, and you see there's a lot of different positive testing, and the interpretation can be very difficult. And generally speaking, you have to explain to the patient that you will find the reason in around 70% of the cases, but in the last 30% you will need to just treat. When you do the testing, there is some different methods you should use. You can look them up, or if you don't know, I can be helpful with it. There's some standard ones, and if you then look at the treatments, there's also, according to the different presentation, different approaches and different medicine groups that helps more and less at the other and different urticaria types. Anyway, but if you look at the end result, of course, when you look at allergy management overall, the strategy, symptoms, you have to look at avoidance. If it's anaphylaxia, you have to give them epinephrine auto-injections. Always consider allergy immunotherapy. I think it's way too little treatment, generally speaking. But of course, the patient needs to be fully committed to it because it takes 3 years as a minimum. Whether it's subcutaneous or sublingual, it really doesn't matter. I prefer subcutaneous to kids and subcutaneous to adults and sublingual to kids. But you can have your preferences. The patient has the preferences, but explain them thoroughly what it's about. Then biological treatments, I think, is limited in our health system due to price, but definitely it's a possibility. And if life is very much affected, I think it should be considered, because the effects can be quite amazing and fantastic in that sense. Yeah, and the gene therapy and personalized medicine, the personalized medicine is getting there, gene therapy less, and and of course probiotics and herbal medicine is a possibility that I don't know that much about. Yes, that was it. Thank you very much. Is anybody still there?
Yes, Professor, of course. Thank you very much for this wonderful and great presentation. It was full of information, and we really enjoyed it. And first, I would like to ask our audience if we have any questions to Professor Ramussen. If not, then I would like to again thank you, Professor, for this very valuable and very wonderful presentation that you did. And thank you everybody for watching.
Thank you.
Thank you again everybody for watching. This was the end of our session today. Thank you for your attention and your valuable time. And this is it.
Hayat hızla akıyor ve biz bu hızı seviyoruz. Her güne heyecanla başlıyor, her anı doya doya yaşıyoruz. İlk günkü heyecanımızla yılları aşıyoruz. Zaman akarken biz de kendimizi arıyoruz. Heyecanla, merakla. Sen de kendini mi arıyorsun? O zaman zamana yetiş. Bu sadece kendini bulmakla ilgili değil. Asıl heyecan kendini yaratmakta. Bir şeyler mi yaratmak istiyorsun? Mükemmel. Metali işlemeyi, bir bina yapmayı, bir iş kurmayı, hatta bir şehir kurmayı öğren. Hayat kurtarmak, teknoloji geliştirmek, üretmek. Hepsi burada. Ve burada tüm deneyimler profesyonellerle yan yana. Ancak hızlı ilerlemeliyiz. Çünkü bugün şimdi gerçekleşiyor ve yarın çok yakın. Hayatta öne geçmek istiyorsan önce zamanın önüne geçeceksin. Hep ileri gideceksin. Bu Doktor Suat İrfan Günsel. Tanıyor musun? Onun da söylediği gibi. Üniversiteler toplumların dokuma tezgahıdır. Toplumları geliştirir, dönüştürür ve gelişmesini sağlar. O burayı bugünden yarına hazırlamak için kurdu. Senin için, ileriye gitmek için. Yana ya da geriye değil. Sadece ileri. Çünkü gelecek çok yakın. Hadi harekete geç. Fikirlerin ne kadar ileride olursa yarına o kadar yaklaşırsın. Yanındakileri de geleceğe taşırsın. Bu senin geleceğin, senin fırsatın şimdi. Hadi yarını yakın. Hepimizi ileriye götür.